I'm Dr. Jamie Koufman, and this is Dr. Koufman's Acid Reflux Hour. You may note that the name is now being changed to Dr. Koufman's Respiratory Reflux Hour, because respiratory reflux is really what I'm interested in, and probably you're interested in as well. Today's topic: why doesn't my doctor know about this? Why doesn't my doctor know about this? The short answer is ignorance and arrogance. The long answer is that the aerodigestive system, meaning the breathing and the digestive system, is all one system. And where it meets and where everything is exchanged is in the throat. And unfortunately, it's been divided into three different specialties: otolaryngology, ENT, pulmonology, the lungs, and gastroenterology. So if you take a system and divide it up, it's like this metaphor. So your car's not running well, and you take it to the garage, and they have three good mechanics there. One specializes in spark plugs and carburetors, one specializes in tubes and hoses, and one specializes in radiators. And the three car doctors look at your car and they say, "Ma'am, your car is running fine. There's nothing wrong with your car." And that's really what sort of happened over time. When my life spans the development of gastroesophageal reflux. It wasn't until 1975 that endoscopes came. Olympus made them for gastroenterologists to do colonoscopies and upper endoscopies. And at that moment, somebody must have said, "There's gold in them Mar Hills." And then the real big change, the real biggie, the real money came when gastroenterologists wanted to have surgery centers to be able to do their endoscopies in their own facility. In those days, you needed a certificate of need. For example, if you wanted to put an MRI in over here, you said, "We're sorry, there's one across the street. You can't do that." But, for example, the state of North Carolina waived those because the gastroenterologist said, "We can save so much money doing these in these little surgery centers rather than the hospital." And so the rise, and it's a massive rise over the course of time since then, it really is surgery centers mostly owned, or many owned, by gastroenterologists. What that means is, when a procedure is performed, there's a professional fee, let's just say $200. And there's a facility fee, let's say $1,800. So now the gastroenterologist, or the team who owns it, is making $2,000 for a procedure that other people may be getting paid for $200. By the way, transnasal esophagoscopy, awake with an ultra-thin, should have replaced EGD, should have replaced gastroenterologists, but they managed to get it changed. It used to be just a professional fee because it was done in the office. But they got it so there was a little bitty professional fee and a big facility fee. It was never intended to have a facility fee, and it was intended for physicians to be able to do endoscopies, look at screen the esophagus for disease in people with reflux, and not have a big, huge dollar amount, and not put people to sleep with the consequences of that, potential hazards. So, to make a long story short, in 1978, I got to Wake Forest University, and a year or two later, I discovered that the world's most famous esophagologist was Don Castell. And Don Castell, unlike me, I eventually had fellows that followed me around for a year, postdocs. But he had a whole room full of them. He must have had 12, because he was the man. And he had ambulatory double probe pH monitoring. I came to him, 81 I'm pretty sure, and said, "Listen, I have patients that have acid reflux based upon inflammatory findings. Some of them had heartburn, but they don't have GERD. They don't have. Most of them don't have typical symptoms. And by the way, the esophageal examinations are mostly normal." And he explained to me that there's no such thing as laryngopharyngeal reflux. And so I borrowed his technology with one of the fellows and put a pH probe in the pharynx as well as in the esophagus, and proved that there was such a thing as as laryngopharyngeal reflux. So that means you have these symptoms, these findings, and then a pH test, which is basically at the time was the gold standard. So we proved laryngopharyngeal reflux associated with laryngopharyngeal symptoms very, very early on. In 1991, I presented a lot of information. I reviewed 8,000 articles and presented my thesis with a large number of patients and basically showed the relationship between reflux laryngitis and subclonic stenosis and a sensation of a lump in the throat and cough, and all the reflux symptoms were related to acid in the throat based upon the pH studies. So what happened was, in 1987, I was already, in 1987, I opened my own laboratory, and I didn't use the gastroenterologist anymore. They were feeling uncomfortable about my publications and my data. But anyway, I had double probes made. So I had a sensor here and a sensor here, high quality, one sensor, and we began collecting data. Around 1987, I coined the term LPR, laryngopharyngeal reflux, reflux into larynx and pharynx. And the reason why I did that is I felt we needed another term. The term GERD, gastroesophageal reflux disease, was associated with heartburn, indigestion, and esophageal disease, literally. So LPR was born, and it was very much proved. So the question of the relationship between the symptoms and the findings of reflux were proof positive. The kind of reflux testing I did never caught on. And I think the reason is that the Medicare reimbursement for reflux testing was not very much. And the disposable catheters that I used, I had custom made, high quality, to measure acid in the throat, basically cost about the same thing as the reimbursement. And then you got to buy the equipment and train somebody, so most people didn't do it. They rely upon gastroenterologists to do impedance pH testing, and Bravo, and some of the GI tests that have developed over the time. Interestingly, I did impedance pH testing for 3 years, and then $23,000 to $1,000 I spent, and then abandoned it because I didn't feel it was accurate to measure reflux in the throat. So, you're going to ask why don't doctors know about this? So just remember, the go-to doctor for reflux is the gastroenterologist, okay? So appeared this year in the American Journal of Gastroenterology, the San Diego Consensus report on symptoms of reflux and its diagnosis. I want to make it clear, this is the single most regressive paper I've read in my lifetime, and it's in my field, and it hurts my feelings, hurts my work. By the way, regressive means becoming less advanced, returning to an earlier, less developed state. So otolaryngology hasn't developed, and basically this paper is the exact paper that was written in 1985. So there's been no progress in GI with regard to reflux beyond the esophagus. And by the way, the term LPR I coined, and about 10 years ago I came with a new one. It's called respiratory reflux, because LPR doesn't say about sinuses and ears and breathing problems. So respiratory reflux is probably a pinnacle term. And then I'd like to get rid of GERD because it's been a wastebasket for so long. Talk about esophageal reflux and respiratory reflux. So they did a poor literature search. PubMed, which I've said was so wonderful, it doesn't go back very far. So all of my articles, all of cell biology, all of the work that I've done, almost none of it, actually none of it appeared in this review. And it's interesting. So I went to Google and I put in Dr. Jamie Koufman, acid reflux, LPR, published papers, and there were like 50 pages of Google on me. Now, some of them weren't published papers, but it's a big difference between nothing and 50 pages of Google. So this paper said that people who have LPR really should have heartburn, indigestion, esophageal disease. It was absolutely no idea about the pattern of disease. So if you get a normal pH study with a gastroenterologist, maybe you only reflux on Saturday night. That's your night where you're not so good. Maybe you reflux once every 2 weeks, but it's all night. The acid and pepsin remain in the tissue. And I want to remind you that acid reflux really isn't acid reflux. It's peptic reflux. So if you go on my website, and I wish you would, JamieKoufman.com, there is an article on alkaline water in which the man it was made out of water, the picture that goes with the article. In that article, there's a biopsy taken from someone who had reflux laryngitis, and on the left side, you see normal staining for the tissue. It shows inflammation. And on the right side, you see the same cut, same stuff, a stain for pepsin. And the pepsin is on the surface. It's deep in the tissue. It's intracellular, it's extracellular. So reflux is about getting rid of pepsin. And acid plays a role because acid makes pepsin, activates pepsin. But there's no discussion of any of this. So the idea is, how long does pepsin last? Well, maybe you only need to have a terrible reflux event, meaning all night it sits in the pharynx every month. We don't know what the threshold is. We do know that the threshold is pH 5 and not pH 4. When they started doing the impedance, I begged Don Castell to not. What he did is anything above 4 was non-acid reflux. I begged him if he was going to put a number to make it pH 5. But they didn't. So if you have reflux at pH 5, you don't have reflux. You have non-acid reflux. So I'm not going to continue to bash this paper, but I want to tell you that there are 12 gastroenterologists, 9 otolaryngologists, 6 speech-language pathologists, and a psychologist. And they think that all of these symptoms in people who don't have proof positive pH testing are psychological. In my opinion, if you have someone who has real symptoms, particularly life-altering symptoms, and you say it's psychological and send them for some kind of head therapy, I believe that's malpractice. So if you don't know what's wrong, you can't blame it on the patient. So in my opinion, there are no people with LPR who have it because they have anxiety. They just don't. It doesn't exist. So anyway, there is a gold standard. I figured it out a long time ago. We were doing biopsies. You could easily take a tiny microforceps, little biopsy, put it in the nose, take a little tiny piece of the pharynx, wouldn't hurt, it would happen fast, and then stain it for pepsin. And that would tell you whether the patient had respiratory reflux or not. Gold standard. Not acid, but pepsin. So if someone wants to be involved or wants me to be involved, that's the way to go. A little tiny piece of tissue, stain it for pepsin. Well, here's the problem. Laryngopharyngeal reflux is not in the GI curriculum. Many GIs they know all my work. I know all the opinion leaders, from Don Castell, Joe Richter and Phil Katz and the big people. They know all my work, but they either say they don't believe there's anything like LPR, or they don't recognize it, but they certainly don't know how to diagnose it and treat it. So now, if you're an otolaryngologist and someone comes with an inflamed larynx or, scarring after surgery that's unexplained, and you want to know whether they have reflux, you send them to a gastroenterologist, and the gastroenterologist says they don't have reflux, it's normal. So they also say there's no diagnostic. Well, there's a diagnostic, and they didn't pay attention to it. The constellation of symptoms. They decided not to use globus and dysphagia. They felt those people needed a big workup. Globus is a sensation of a lump in the throat, and dysphagia is difficulty swallowing. These two have a very specific pattern. We've studied it. Globus can occur with low pressures, high pressures, or even very high rebound pressures. For example, up to 200 millimeters of mercury after swallowing. And the difficulty swallowing, the dysphagia, is hysterical. It's called dysynchrony, and the valve closes in the middle of a swallow. So we tell us right there. I started studying this a long time ago, and these people all had abnormal pharyngeal UES manometry. And then we tested them after the reflux was effectively treated, and they were all normal. So these people have globus and dysphagia secondary to respiratory reflux, and it's sort of the last barrier itself that's inflamed, and it's the upper esophageal sphincter. So we have constellations. First, a sentence has to be said. Because the go-to doctor is the gastroenterologist, all the other doctors dealing with the airway. I feel sorry for the pulmonologist, because almost all pulmonary disease can be either caused by, worsened by, or accelerated by reflux. And I've pulled people out of, I've said this before in my career, out of the lung transplant line. I've taken people who had COPD and thrown away their oxygen, improved non-smokers with COPD. Think reflux. So the problem is you don't have a doctor. So if you have respiratory reflux, which most of you have, seeing me, you are the doctor. I tell this over and over and over. I broke my hip, captain of my ship, orthopedist. You have respiratory reflux, you are the doctor. Now, that means when I get to these questions are not, they're like little nibbling questions. You know, like I want to improve. I want to have a nice yard. I want to landscape it. And so you think the thing that has to be done is you have to go out there and get all the crabgrass out. It's not going to give you a beautiful garden. Similarly, just being on a diet will help, may help. Reflux is a chronic disease. Lower esophageal sphincter gets stiff and swollen. More reflux, more stiff, more swollen. Often the esophagus gets lazy. Dysmotility is secondary. Don't get on pills for that. And then the upper valve kicks up. So when you lay down at night, what's in your stomach is in your esophagus, is in your throat. So the reason why doctors don't know anything about this is there's no test for it. There's no doctor who understands it. One. And you say, okay, well, how could one? Well, the answer is my nature is to always be unhappy with the status quo and try to make it better, especially better instrumentation, better testing, better everything. So that's who I am. It's in my nature. But I'm an academic. So, for example, when you talk about how does Pepsin injure tissue, we've done cell biology. We've actually looked at it, and we can tell you. We can tell you what kind of enzymes intracellular are depleted. We know a lot, but none of it is recognized by GI, the go-to doctor for reflux. So I don't want to belabor it, but I think that what has to happen is someone, with my help, perhaps, will develop a tract. Say, if you're going to be a primary care physician, integrated area digestive medicine. Maybe a PA group will have integrated area digestive medicine. Because not only are you going to have to understand some otolaryngology, some pulmonology, and some gastroenterology, crossing those boundaries, but you're going to have to be able to examine the throat. So you can't just go, you're going to have to learn to put a small scope in and look at the pharynx. So that said, the symptom, the constellation, postnasal drip, it's thick, chronic throat clearing, cough, globus, feel like sinus pressure, all these symptoms, there's no other diagnosis. And by the way, shortness of breath, I'm going to talk about in a minute, is very, very common in people with respiratory reflux. So, is there a diagnosis test? In my opinion, there is. I don't have a picture to show. But the back of the larynx, it has a name, the back of the voice box when you look inside. It's called the postcricoid area. And there's usually space between the postcricoid area and the back wall of the pharynx. And when the postcricoid is so swollen that it's in contact with the posterior pharyngeal wall, the patient has snore, supine nocturnal respiratory reflux, diagnostic. In addition, people who have globus and dysphagia, just like I've described. By the way, many of them say, do you notice the globus when you're actually eating? And I go, no. It's difficulty swallowing. The constellation coupled with examination, and it's not redness they're looking for. The kind of inflammation is mostly swelling. But the easy one, the one I can tell every otolaryngologist in the country, is when the posterior larynx is in contact with the back wall of the throat, you got supine nocturnal respiratory reflux. So I think this has probably been fragmented, and I'm not sure how to correct it, other than continue. I'm a pioneer. My work is, I know where the problems are. I don't know when people reflux. There's one reflux a week. Keep this going. We just don't know enough about the mechanisms. But the GIs don't even have equipment to begin to look at it. So you can forget about the GIs. The GIs are basically on the wrong planet. So I'm going to answer some questions. Some of them, and let me make a comment here. I wrote JamieKoufman.com as my next book. I'm writing a book, Respiratory Reflux, The Cause, Cost, and Cure for America's Silent Epidemic. You know, when I go give a lecture to 100 otolaryngologists, I say to them, at least 50 of you have respiratory reflux, silent reflux. Eat late, go to bed, reflux. Eat at 8 o'clock, go to bed at 10, all of you have reflux. So I want to make a comment that I'm not sure how I'm going to handle it, but I think next time I'm going to talk about reflux treatment, meaning Dr. Koufman's respiratory reflux program, and it's not just a diet. It's low acid, low fat. It's not just taking a Gaviscon or some other alginate. And so I will talk about that next time. But what I want to make a comment here again, reiterate, is if you have reflux, you're basically the doctor. People say, is there a better, someone like you in San Francisco near me? And the answer is no. In addition to it, when's the last time you had a doctor spend 30 minutes talking to you about diet and lifestyle, which is what I do when people do consultations, figure out how to stop this. Diet and lifestyle is part of it. And so is the Gaviscon and the other stuff. So it's a program, a detox. Here's the idea. You have this chronic disease. It's been percolating along. Oh, and you get bad. No, you go on medicine. It gets better. It's percolating along, percolating along. Something else happens. You go, now I get a cough, and eventually it gets better. You need to stop the reflux 100% for at least a month to stop it. First, basically, have a healthy esophagus and esophageal valves. So it's doable. You can heal reflux. You can make the lower esophageal sphincter better. So exercises, which people don't do it, treating the vagal nerve somehow doesn't do it. And by the way, if you have reflux, you absolutely should not be on gabapentin and amitriptyline, nortriptyline. All these medicines are for neurogenic syndromes, which are very uncommon in my practice. So I'm going to answer some questions. I hope that I've been able to communicate that we have, it's a black hole, reflux, actually. I don't think the gastroenterologists know anything about reflux. Can Pepsin, the treatment of Pepsin, by the way, can Pepsin reach the eyes and damage them? Loretta asks. I don't know. If there's a mechanism, I don't know it. I don't think so. Is burping a sign of reflux? Mercedes wants to know. Yes, it is. Think about it. There's air in the stomach, the valve opens and up it comes. And often we think of it as aerosolized reflux. Not been studied, but people who are big burpers are big refluxers in terms of respiratory reflux when you examine them. And by the way, I can examine you and tell you whether you got sleep apnea. I can examine you and tell you the severity and length of your reflux. You've been doing it for 20 years. By the way, that's how you get sleep apnea. 20 years of supine nocturnal respiratory reflux. I'm starting a detox version of your diet. I cut so many foods. I've been so much better, but I've had a bad flare-up. So what do I do? And the answer is, just as I suggested, that you have to enter a detox program that is using every tool you have. For those of you who know sports, and basketball in particular, there's something called a full court press. It only works if every man is covered, every woman is covered, if they're all covered. And the same thing is here. Every part of this, I mean, for example, read the article on gum chewing after meals. More saliva, more bicarbonate, more swallowing. So there's a big program. I have your book, and it's unclear about seasonings. Basically, to my knowledge, everything's okay except anything that contains capsaicin. There are people who have problems with garlic and onions, so we don't use that or flavorings for it. But the normal, rosemary and thyme and things we use to cook with this, they're fine. A question, Sharon, whether gallbladder problems can be the root cause of LPR, and I don't know. I don't think so, but I don't know. There's no way for me to be sure. To what extent can LPR, this is a good one, Kristen, to what extent can LPR affect the face and sinuses? Can it cause persistent facial redness, warmth, swelling around the nose and cheekbones? No. So it doesn't cause things that you can see on the outside, but it can affect the sinuses, and all the sinuses get thick lining, and you feel facial pressure and pain. So the symptom of facial pressure and pain can be very much, especially, it's both sides, very, very much related to reflux, but the external redness and so on, I don't think is related to reflux, or I can't explain it. It could be some kind of vagal connection. Can you please address the subject of water brash, persistent sour taste? If you have water brash and sour taste, you're in the championship division. You're in the top 5% of bad refluxes in my practice. Okay, if you wake up with a sour taste in the morning and it's basically you're tasting your refluxate, then you need a big program. And it's not a surgical program. It's a big change. If you drink alcohol, you're going to stop. If you eat, at 6 and you go to bed at 10, you're going to change it. So there's a big program. I'm talking about next month's topic is going to be how do you cure reflux? Again, these partials. Taking 100 milligrams of famotidine daily, just during bad episodes. What do I do? Back and forth. And the answer is, it's percolating along. Something happens to get worse. Oh, the famotidine makes it a little better. But the real proof that the reflux is chronic is that with GERD patients who have heartburn, about half of them will get real relief from heartburn. And so I stay on PPIs. Beautiful study, Danish study, I've referred to it before, 10,000 people. Long-term use of proton pump inhibitors increases your risk of esophageal cancer. And it's not that the drug is carcinogenic, it's that the reflux just goes on unattended. The symptom, heartburn, apparently is better. So, it's got to be stopped, and stopping is a big deal, and it's not about a better gun. You don't need a better gun. The reflux howitzer is not going to take care of it. I'm going to answer two because I think it's important. I have a question from Susie about does Gaviscon extra strength deactivate Pepsin? First of all, I don't recommend Gaviscon extra strength. If you buy it in this country and it's Gaviscon extra strength, it's not real Gaviscon. It's an antacid. Gaviscon Advanced is the name of the product. And the other two are Reflux Raft and Reflux Gourmet, and they're alginates. I have no idea whether nobody studied what they do to Pepsin, but they certainly are helpful in reflux treatment, and it can be a big difference maker. So it's one of the things that we recommend, and I recommend during treatment. Does the LPR get loose with LPR? Does the lower esophageal sphincter get loose with LPR? And the answer is the lower esophageal sphincter, the connection between the stomach and the esophagus, is the first, when that opens inappropriately, up comes stuff. And we've studied it to some extent. When you do manometry, the only number you can't really trust is lower esophageal sphincter pressure. And the reason is it seems to record the highest pressure that it sees during the study, and it doesn't tell you if you have a low. If the answer is zero, if you have no LES pressure and it's zero, then zero is a loud number. But generally speaking, everybody we assume has lower esophageal sphincter pressure who has reflux. There was one other question, and the answer. Oh yes. Should alginate be taken before or after a meal? The answer is after. Gum chewing or hard candy after. There's too many people taking gabapentin and amitriptyline and all that. That's not a treatment for reflux. So, I hope this hasn't been so scattered that you can't get good information. I was very concerned about giving this talk because, I've lectured to all these people. I've been everywhere. I've published everywhere. If you want to see my curriculum vitae, go to jamiekaufman.com, about us, go down about bottom of me, and click curriculum vitae. And you'll see the publications and the places where I've lectured everywhere. And yet, it's had no impact. People continue to do what they were doing before, and I've just not been able to influence it. And the answer is, I'm not a big enough force. I will say, when my respiratory reflux book is published, I think it'll change things. It'll be slow changes, but people will start to look at integrated air digestive medicine, and they'll start to look at much more inexpensive and effective ways to treat reflux. So thank you very much for listening. jamiekaufman.com, jamiekaufman.com. I'm not blogging right now. I used to do one every week because I'm trying to finish this book. Right now I've got 418 pages of manuscript and I'm not done. So clearly there's some editing needed. So good luck. Not one piece. One thing's not going to make your reflux go away. If you read my blog an hour a day for 7 days, at the end of those 7 days you'll know more about reflux than 99% of the physicians in the world. Again, thank you very much.